Good morning and good afternoon. Welcome everyone who is online and joining us today for our World CML Day seminar. My name's Andrew Smith. I'm from the Leukaemia Foundation of Australia, and I'll be the host for today's session. September is Blood Cancer Awareness Month, and every year on the 22nd of September, the blood cancer community unites to recognise people living with chronic myeloid leukemia, CML, and raise awareness, celebrate breakthroughs in treatment, and acknowledge what still needs to be done in this space. We're really proud to bring you this free live webinar. The session will be run for approximately 1 hour, and we want to welcome anyone to use the Q&A function and ask some questions that's on your screen. We'll have a moment halfway through the talk to answer some questions, and then we'll have a bit more time at the end of the presentation for some more questions. Also, the presentation will be recorded and available to watch back at a later date via our YouTube channel, which you can find by visiting www.leukemia.org.au. All right, it's my pleasure to introduce our guest speaker today. Professor Tim Hughes has seen CML transform from a universally fatal disease in the 1980s to a chronic disease requiring lifelong therapy in the 2000s, and now to a disease where treatment-free remission is possible for many. He is the Precision Medicine Theme Leader at the South Australian Health and Medical Research Institute, a consultant haematologist at the Royal Adelaide Hospital, and Chair of the International Chronic Myeloid Leukemia Foundation, along with other leading roles in the field of CML. So without further ado, please welcome our guest presenter today, Professor Tim Hughes.
Okay, thanks very much, Andrew. It's a great pleasure to be here on World CML Day, and I thank the Leukaemia Foundation for their great support over many years for people with chronic myeloid leukemia and research into chronic myeloid leukemia. It's been very critical support. So it has been exciting to be involved in the evolving story of chronic myeloid leukemia from the time when all we could really do was palliate, make people comfortable in the last century, to more recently having the potential to keep this disease under control for the duration of somebody's life. And then more recently, the understanding that in fact for many patients, it's possible to actually maintain remission off drugs altogether. And that's become one of the major foci of our research in Adelaide. So I'm going to cover some background information. I don't know, a lot of you would have a great familiarity with CML, but some probably will not. We'll cover the importance of the molecular monitoring and the molecular milestones, talk about the various TKIs, the tyrosine kinase inhibitors that are the backbone of the treatment of CML. Focus on treatment-free remission. I think we'll take a break after I finish talking about the TKIs before we move on to treatment-free remission, just to give us a chance to ask questions that are more focused on the two sections. Then talk about something which I'm very excited about, a new drug which has become available, at least in the clinical trial setting, Imatinib. Finish with some comments about the very exciting movements towards a national strategic action plan for blood cancers, and then some conclusions. So I'm going to mention some abbreviations in my talk, so I thought I'd better bring them out front so that when I just slip them in, you're going to know what I'm talking about, or hopefully will remember what I mentioned. So CML is chronic myeloid leukemia. Bcr-Enabled is the actual mutation that drives this leukemia. It's the fusion of two genes, one called BCR and one called ABL, which when they are separate, doing their normal function, are very important genes that do a lot of important things in the cell. When they fuse together, they create all the abnormal behavior that we see in a chronic myeloid leukemia cell. So that's very much a focus of our research. Now, the RQ-PCR test is the way that we measure the amount of the Bcr-Enabled in the blood, and that's actually a way of measuring the amount of leukemia that's present in the blood and the bone marrow. So it's a very good correlation between the amount of Bcr-Enabled transcript that we measure in the blood and the amount of leukemia that's present in the patient. And I'll show you the illustration of that in a moment. And then we have various definitions of response. We talk about an early molecular response, which means being less than a level of 10%, which I'll show you in a moment. We talk about major molecular response and deep molecular response, MMR and DMR. I'll illustrate those very clearly in a moment. Treatment-free remission, we've already mentioned, TFR, and TKIs represents tyrosine kinase inhibitors. So before we had the availability of tyrosine kinase inhibitors, the natural course of the disease of CML was pretty predictable. It would remain in the chronic phase for somewhere between 4 and 6 years. Then it would become more difficult to treat with the drugs we had available then. We'd go into an accelerated phase, and at some stage would go into a full-blown blast crisis, which is very much like an acute leukemia, which is life-threatening. And that was the typical pattern that we saw in the 80s and 90s when I first started treating patients with chronic myeloid leukemia. That's all completely changed now with the development of the tyrosine kinase inhibitors. So how do they work? Well, this is an attempt to explain that. Here we see the molecule which we call Bcr-Able, and that's that fusion of 2 genes that creates this fusion protein called Bcr-Able. And that is that's the protein that causes all the trouble in the cells with chronic myeloid leukemia, because they, by binding with ATP, cause a whole lot of downstream activities that drive the CML cells to multiply too many times, to not die when they should die, to do all sorts of things that create the problem of chronic myeloid leukemia. And it became clear in the 80s when we started to understand this was the driving force behind chronic myeloid leukemia, that if we could just prevent ATP from binding to this protein, we might be able to stop the disease behavior. And that's exactly what we've done with the tyrosine kinase inhibitors. We've developed these small molecules that can bind in the same pocket as the ATP molecule, and therefore prevent ATP from binding, and therefore turn off this activity of Bcr-Able. And that's what we call the tyrosine kinase inhibitors, and that is exactly how they work, by binding in that pocket and switching and making it impossible for ATP to bind, and switching off all of this signaling that's driving the leukemia. And that has proven to be a dramatically effective treatment for CML. So this is how we measure the amount of the Bcr-Able transcript, and it correlates very strongly with the amount of leukemia present in the patient. So this is actually showing you a real patient that we started treating about 20 years ago, and we're measuring it on what's called a log scale. So we have 100%, so virtually all the cells are leukemic, 10%, 1%, 0.1%, 0.01%. So it's shown on what's called a log scale, where each division goes down tenfold. And it's a very good way to show the progress of the response. So for this patient, starting at 100%, they fell very rapidly down to a level of 0.001%. That's a remarkable fall after about 1 year. And that demonstrates to us that these kinase inhibitors can reduce the number of leukemic cells from very, very high numbers to very small numbers quite rapidly. But what happened in this patient was he had to stop taking his TKI because he had other diseases not related to CML. And what happened was this very dramatic rise up to the level of 100% again within a few months. So that tells us, first of all, that what we're measuring here with this PCR test, it correlates very strongly with the amount of leukemia present in the patient. And when you see this sort of dramatic rise, it means one of 2 things. Either the patient has stopped taking the drug, which can happen in some cases for various reasons, and that was the reason in this case, or because the patient develops resistance to that drug. We call that drug resistance, and that can also cause this rapid rise in the level of leukemia. But that's why we measure the PCR level virtually every 3 months to see how the patient is progressing over time. This patient actually was able to restart their drug, went back down again, but had to stop again, went back up again. So this was the first illustration that we had a very, very sensitive and accurate window onto the leukemia simply by measuring the amount of the Bcr-Enabled transcript in the blood. So what we were quite surprised about when we started to follow patients was the variability or the heterogeneity of the response. Since every patient has the same Bcr-Enabled present in their cells and we're using the same drugs, we were very surprised to see the variability in response. So that in about 10% of patients, we didn't see a dramatic fall in the level of the transcript over time. And in about another 10%, we saw the fall, which was great, but then they saw a loss of response when, and as I said before, in most cases, that's due to drug resistance. So we have about 20% where we're not happy with their response, and we have to use second generation or third generation kinase inhibitors to try and get better response. And in some cases, we have to take these patients to a bone marrow transplant because we can't get an adequate response with a tyrosine kinase inhibitor. But the vast majority of patients do respond, and there's about 30% or a third that come down very nicely and then tend to plateau. They tend to flatten out without falling over time. And for many of those patients, we do try and use more potent drugs to get them to a deeper level. And why do we want to get them to a deeper level? Well, that becomes clear because about half the patients do achieve what we call a deep molecular response. They go well below this initial target of an early molecular response at 3 months. They go down below the level of a major molecular response, which is 0.1%, and they go down to a level of a deep molecular response, and they then maintain that for several years. And about 15 years ago, we started to wonder whether some of these patients may no longer need their tyrosine kinase inhibitor. And so we started trials where patients who had actually been negative by our PCR test for a couple of years, we tried stopping the drug. And what we showed then, and other groups in France showed as well at the same time, was that when we stopped the drug in these patients, about half had a very rapid rise, just like we saw in that original patient. We had to restart their drug, and they went back again to a deep level. But about half the patients didn't have a rise at all and remained virtually negative for detection of the leukemia. And I now have some patients who've been going 13, 14, 15 years off drug, remaining either PCR negative or at extremely low levels of leukemia and not rising. And I think that some of those patients may in fact be cured, but we won't know that for another 20 years, I guess. And we follow those patients every 3 months. So that's been one of the most exciting findings, I think, in CML research, the fact that we can stop these drugs in some patients. And that's important because these drugs can have day-to-day toxicity, as we'll talk about, and they can also cause damage sometimes to the kidneys, to the lung, to the heart. That can be a problem in the longer term. So getting off these drugs clearly is an important target. And our research is really focused on understanding why there's such variability in response by studying these cells at diagnosis. We look at in detail at genetics of these cells. We look at the immune system in these patients, try and understand why some patients do this and other patients do this. And that's still an area of very active research. We're also focusing on this point where we stop the drug, trying to understand why some patients have this rapid rise and go back on their drug, and some patients don't need to go back on at all. And we're getting some really interesting results about that, and we can talk about that in the questions section later on, perhaps. So based on these sort of observations, the what's called European Leukemia Net, which really is a group of people that come together, and I'm on their committee to make recommendations about what we should regard as an optimal response, meaning that the patient is hitting their what we call the molecular milestones, and we're happy with their response, and it's very likely that they're going to live a long and healthy life because they're achieving great response. And we call that an optimal response. You see that in green here, and that is really defined entirely by the level of the leukemia transcript measured by this PCR test. So as long as you're below 10% by 3 months, as long as you're below 1% by 6 months, as long as you're below 0.1% by 12 months, we regard that as an optimal response. And the reality is that patients who do that have a survival that's equivalent to age-matched people that don't have CML. So it's remarkably good outcome. Now you see that there we have in yellow a warning category. I'll mention that in a moment. We also have a treatment failure category. If you're above 10% beyond 3 months, and if you likewise stay above 1% beyond 12 months, we call that treatment failure. And the recommendation is to switch to a different drug, a more potent drug, and to try and get down into an optimal response if possible. And if not, to think about further changes in therapy until you do achieve a better response. And then we have this sort of middle group here where we say, well, they might be heading towards failure, but maybe with a slightly increased dose or more careful adherence to taking the drug every day, we might be able to push it down into an optimal response. We watch them closely to decide which way to go for those patients. Now that's what's called the molecular milestones when we're focusing only on survival. If we're focusing also on trying to eventually achieve treatment-free remission, that becomes a little bit more ambitious, where we also want patients to get below 0.01% by 24 months. So you see this is now, the warning group has got a bit larger here. We're a bit more concerned in these patients who aren't quite achieving a deep response by 2 years and considering whether it would be appropriate to try a more potent drug for those patients. So that's why your hematologist will look at your PCR result and say, I'm really happy you're having an optimal response, or I'm a little bit concerned, we're not quite where we want to be, I think we need to do this or that. So that's why this is an important focus on how the response is going. And I think it's helpful for you to track your PCR response over time according to this chart of the molecular milestones. Now, one of the challenges we've had in CML is that we've developed first-generation drug, which is Imatinib, and we'll talk about second and third-generation tyrosine kinase inhibitors in a moment. But for each generation of these TKI drugs that have been developed, we've achieved greater potency, and that means more effective blocking of the activity of Bcr-Enabled, but we've also had a counterbalancing effect of increasing toxicity. So in the randomized studies that have compared Imatinib, first generation, to either Nilotinib or Dasatinib or Bosutinib, which are second generation drugs, there hasn't been any improvement in overall outcomes, because any slight improvement in the effectiveness against the CML has been counterbalanced by an increased toxicity because of the more potent drug. So that's been one of our challenges. So the result has been no clear advantage for any one TKI. And that's why when you first see the hematologist in the clinic, they won't say to you, well, the obvious choice for you is A, because that gives the best outcome, because there are arguments in favor of A or B or C, depending on your specific circumstances. Let's talk very briefly about Imatinib. That's the first TKI that was developed. It's a very, very safe drug. It can impair kidney function over the long term in some patients. Otherwise, it has very little toxicity, but it does have side effects. It can cause muscle cramps, nausea, diarrhea, fluid retention, skin rash. These are all concerns that may lead you to want to switch to a different drug, or may lead you to try and address those symptoms more aggressively. The standard dose is 400 a day, but you can use doses between 300 and 800 a day, depending on the circumstances. Nilotinib is a second generation TKI. It's more potent than Imatinib, and therefore we do see better molecular responses overall. And because of that, this is a little bit controversial, but certainly my belief that we have a better chance of achieving treatment-free remission using this more potent drug than we do using Imatinib within a time scale of 5 to 8 years. I can't tell you whether maybe Imatinib will lead to just as good responses over 20 years, but certainly in a time scale that's limited, you're more likely to get to a treatment-free remission with one of the more potent drugs. It's generally actually well tolerated, but you do need to fast twice a day, which can be a real challenge for a lot of people. For the patients, particularly over 60, there is a concern about an increased risk of heart attacks, strokes, blockages in the arteries in the leg. That risk was shown to be 16% over 10 years, compared to just 4% with Imatinib. So it's a significantly higher risk that needs to be considered and addressed. Standard dose is 300 milligrams twice daily. Dasatinib is the other second-generation drug that we can use in Australia. It's also more potent than Imatinib, and it also causes better molecular responses. It does lead to a higher risk of these vascular events that I've mentioned, but we don't know exactly how that compares to nilotinib. It may be a little bit less than nilotinib. We don't have all the data to really say that. It also does lead to a risk of what's called pleural effusions, which is fluid around the lining of the lung. And that can become a problem for some patients, particularly in older patients, and particularly at the higher dose of 100 milligrams a day or higher. But many patients can get very good responses on lower doses. 50 milligrams a day has been the dose we've used in most patients in the most recent trial in Australia, and it looks very effective and quite well tolerated. So I think that's a very interesting drug that also needs to be considered. Panatinib is the drug we use as a last choice. It's a very potent, we call third-generation TKI. It's actually active against many of the mutations that we see in Bcr-Enabled that lead to resistance to the other TKIs, but it has an even higher risk of vascular events. The standard dose is 45 milligrams a day, but we often use lower doses because we're trying to modify that risk of these vascular events like heart attacks and strokes. So at that point, I'm going to stop and return it to Andrew for any questions before we move on to talk about treatment-free remission.
Fantastic. Thanks, Tim. We've got a few questions coming through, and just a reminder for people to jump onto the chat function and send your questions through. So the first one we might start off with, really good question, for what is the recommended approach to pregnancy planning for somebody with CML, and also what are the risks involved?
That could take me a long time to answer. I'm going to just give some broad principles. Basically, we know that the TKIs are not safe to be given during pregnancy. So that's very much our priority, is not to use them during pregnancy. Some groups overseas have actually used them in the last trimester, and there's no evidence that's necessarily damaging, but we know that used in the first trimester and perhaps the second trimester, there is an increased risk of fetal abnormalities. So we, at all costs, try and avoid using them. So the ideal situation, if you're a young woman who wants to start a family, is to get into treatment-free remission, get off your TKI therapy, have a stable response, and you can therefore go ahead with some level of confidence that you can proceed with pregnancies and start a family. Not always possible. Sometimes people need to go ahead with their family plans before they can actually achieve a treatment-free remission. Broadly, I would say the deeper you can get your response, the longer your exposure to a tyrosine kinase inhibitor, the safer it will be to come off that inhibitor to have a child. It's never without some risk, but we can often modify that by, during the pregnancy, using interferon, which can modify the leukemia somewhat. But there is always going to be some balancing that risk to you against that hope of having one or more children. So it's a complex situation. I don't think I can really do it justice in this brief session, but they're the broad principles.
Excellent. Thanks, Tim. The next one, you mentioned in one of your slides around initial consultations with people's haematologists about which TKI to use. What are some of the considerations that our patients that might be listening today, what are some of the things that they need to make their haematologist aware of when having those initial discussions about which TKI is most appropriate for them and their individual circumstance?
Right. I mean, so we have the luxury in Australia of the choice of 3 really good drugs to start with. And for most patients, that'd all be great choices, but we try and make the best choice for the patient based on a number of factors. We do assess the actual, what we call the risk score of the CML. And that is classified as either low, intermediate or high. And even if you have high risk CML, the overall survival is still excellent, but it just does mean that we would tend to use a more potent drug for patients who have what's called a higher risk category of CML, and we assess that by the size of the spleen at diagnosis, the number of platelets in the blood, a number of other parameters that are easy to determine. So that should always be measured at diagnosis. The second important thing is, does the patient have other, what we call comorbidities, which is other illnesses? If the patient had several previous heart attacks, or a stroke in the past, you wouldn't consider using the second generation drugs that have this higher risk unless you absolutely had to, maybe as a second or third line of therapy. You'd use Imatinib, which we know is very safe in that setting. The third consideration is how important is treatment-free remission to the patient. If it's a really important principle, then you might decide to use a second generation drug such as Nilotinib or Dasatinib front line rather than Imatinib. But if you were an elderly patient who's rather frail, you may be preferring to use Imatinib, a safer drug, and leave the second generation drugs to if you needed it, if you didn't respond well to Imatinib. So the other three broad considerations: the risk score of the CML, the patient's medical history and whether they have other illnesses, and thirdly, the priority for treatment-free remission.
Excellent, thank you, Tim. A few questions coming through about side effects of TKIs. We might hold some of them off. They are specific, but one more question. As a CML patient who has a Bcr-Enabled not detected for over 9 months. And have been told treatment-free trial will not be considered until 2 years at 0.01. What is, I suppose the question is, what is the reasoning for the TKI not to be decreased if the person has no other problems or symptoms?
Right, there have been trials reducing the dose of the TKI. And that can be just as a long-term strategy to reduce the toxicity of the drug. And as long as you're maintaining the same PCR results, so you're maintaining your molecular response, it's no problem at all, I don't think. That's the key. If you're losing your molecular response, then that lower dose is not satisfactory. You need to go up again. There has been a trial where, in fact, they halved the dose for 12 months and then stopped. And that seemed to be a successful strategy as well. So that's something you can discuss with your clinician. But generally, our approach is to try and get as deep response as possible to the point where we are confident that the patient has a good chance of success when they stop. And that means better than 50% and then to stop. But we're going to discuss that in more detail in the second part of the talk.
Beautiful. I might have one last one before we jump back into the rest of the presentation. So the question is, when you say you think patients might be cured, do they still have detectable disease, or do you think these patients are disease-free?
Yeah, it's a great question, and it's one of the questions that's been sort of going around for a while. Do we actually eradicate every last leukemic cell in the patient? And we actually showed about 10 years ago that even when the PCR test shows a negative result, and this goes on over, for 10 years after a patient stopped their therapy, if you use a really, really super sensitive test, which is complex and expensive and takes a lot of time, you can still show a small amount of leukemia is present. So I don't think we can say with any great confidence that we can ever eradicate every last cell. And the reality is that nothing would ever be able to prove that, because there could be a cell hidden away somewhere that you'll never be able to detect. So we haven't got the sort of technology that could ever prove that you've removed every cell. But does that really matter? It probably doesn't matter. If you stop your drug and then 30 years later die of natural causes, you probably were cured. The disease was not capable of coming back, even though you stopped your therapy. So to me, that's the focus that I think patients should be looking at. Can I stop my drug safely and maintain zero PCR or virtually zero PCR over the long, long period? And I think for many patients, that is possible.
Excellent. Thanks, Tim. We might throw back to the presentation.
Okay. So I mentioned before that the European Leukemia Net has these recommendations that come out every 5 or so years. Well, for the first time, they've just published the 2020 recommendations. They've actually acknowledged that treatment-free remission is a significant new goal of management. And they recommend that consideration of treatment-free remission in appropriate patients, after careful discussion, employing the concept of shared decision making. So it's not for the hematologist to say you must stop or you must not stop. It's for the hematologist to tell you what are the possible consequences of stopping today versus stopping in 12 months or in 24 months, and then making a shared decision. But what's really we don't want to happen is for patients to decide, well, I know my doctor says I shouldn't stop, but I'm just going to stop anyway. That's the worst situation, because in that case, the hematologist is not following your disease closely. He's just doing his routine 3-monthly testing, and it may be very, very high level before you discover that you've actually relapsed. So if you're going to stop, it needs to be done in partnership with your hematologist so he can monitor you appropriately. Even if they don't recommend it, you're still able to say you want to do it, but you need to talk to your hematologist about it. It's an important point. And in some cases, they acknowledge that treatment may be changed to a more potent drug, a second-generation drug, to improve the depth of response in selected patients when you're not achieving a deep molecular response on Imatinib. So I've got a few slides just illustrating how I approach this question. And I guess if this is the patient journey, then if we focus on right at the start, I think it's important to talk to the patient about what is their assessment of how important treatment-free remission is to them in the long term. Some patients do say to me they're more focused on just avoiding any symptoms. They don't particularly care whether they're on drug or off drug. So it's an important discussion to have right up front to understand how that might impact on the choice of drug that the clinician and the patient come together to make. As your response is falling steadily, the focus for the clinician is to optimize that response to keep you in that so-called optimal zone, hitting your molecular milestones. And if you're not doing that, and you do want to achieve treatment-free remission, then what we tend to do is to switch to a more potent drug to get you back on target to a deep response so you can eventually look at treatment-free remission. When you do achieve a deep response, the critical thing is to make sure that you maintain that and to document that over time. Sometimes, for various reasons, PCR tests aren't done quite as regularly as they should be done, and you don't have that confidence that you've maintained that deep response for at least 2 years, because that is the amount of time that we know from many trials now it's a safe place to stop drug. We don't have any evidence that a patient who's just hit a deep response can safely stop. Those studies have not been done and it's not recommended. So we want to document that you've achieved that deep response and maintained it for 2 years. The exception would be a patient who wants to stop because they want to have a child, and we accept the fact that there is an added risk there, but there's also a considerable bonus in terms of starting a family. But in the broad category of patients, we want them to achieve a documented deep response for at least 2 years before we start considering the possibility of treatment-free remission. And once you get to that point where you're eligible, it doesn't mean that we say, well, let's stop today, because the reality is that while your chances today might be, say, 50-50, with another year or so of therapy, they might be a lot better than that. So trying to work out what's the right time for you to try to have an attempt at treatment-free remission, but also to manage the expectations, to understand that it's not a guarantee that you'll be able to remain in remission. You may need to go back on drug. That's not a tragedy, but it is a setback. It means you're back on the drug that you were trying to get put in the past. But I think you need to understand that that can happen and be prepared for that eventuality if it does happen. Once you stop, that rigorous monitoring, everyone agrees it should be pretty much monthly for the first 6 months, and then you can slightly relax, but you need to keep going with 3 monthly testing probably for the rest of your life, because we don't really know what happens after 10, 15 or 20 years. We don't want to have patients come back to us with relapse because we stopped doing the PCR testing. So you might be free of the drug, but you're not free of the testing at any time, I don't believe. You can perhaps argue that, but I don't believe. And then long-term monitoring, as I said. What about for the patient who doesn't remain in the deep response? Well, our category, and that's pretty much agreed around the world now, that if you go above that level of a major molecular response, above that level of 0.1%, we restart the drug. And what generally happens is you fall quite rapidly back down to the level that you were at before, but about 5% of patients don't go down quite as deep as they were before. So that's what we'll mention in a moment as one of the risks of trying to achieve a deep response. You might not get back to as deep response as you were before. 95% of patients do. So, and this comes up a lot. Is it really safe? Well, I'd say to you now that we have clinical trial experience of well over 2,000 patients, and it does appear to be safe if it's done under the strict criteria that are the recommendations of the CML clinicians. And what are the risks? Well, the risks are we do see this thing called withdrawal syndrome. In about a quarter of patients who stop, they get tired, they get achy in the joints. It can be quite debilitating, and it can be quite alarming for some patients, particularly if they're not warned about it. I had a patient come back and say, I think I've got my leukemia back because I've got all these aches and pains back, and they were very, very worried. But in fact, their PCR was 0. It was just this withdrawal syndrome. You need to be aware it can happen. It's virtually always self-limiting. That means it goes away over time. I've never seen a patient where it's persisted beyond about 12 months. It's very rare that can happen. Some patients need to go on to steroid therapy for a period to damp it down, to make it more controllable. But it's not a life-threatening. It doesn't seem to do any damage to any of the to the heart, the lungs, or other organs. The other danger is what we call this rapid molecular recurrence. So if it does come back, it can come back very quickly. And if you're not really on top of the PCR monitoring, if you go for a holiday and forget to have your PCR test, or you don't ring up the doctor to check your result, you can find out because your blood count actually becomes abnormal. We call that hematological relapse. And if you miss out your testing for, say, 3 or 4 months, that can happen. So it's really important to adhere to the PCR monitoring, particularly in those first 6 months. But even beyond that, slightly less frequently. As I said before, 95% go back into the deep molecular response, about 5% don't. I'm not sure if that's because those patients are maybe discouraged and not taking their drug quite as religiously as they were before. I don't know for sure. And of course, we have to acknowledge that there is some stress involved in stopping your drug, and this fear of having to go back on the drug is real, and having to have a test every month and getting a result. Is it good? Is it not good? That can be quite stressful for the patient as well. So that needs to be acknowledged, and some patients will want to get psychological support for that period. I think that's very reasonable. And of course, a risk of late relapse. We do see some patients who are PCR negative for 4, 5 or more years and then do suddenly become positive. In fact, it's not usually a sudden relapse, it's usually a gradual relapse. And in our experience, if patients are PCR negative at 2 years after stopping, we've never seen a patient actually relapse. But it's, of course, a theoretical possibility, and it's the reason we want to keep on monitoring indefinitely. What are the 6 questions that I consider when discussing treatment-free remission with a patient? First of all, are there any contraindications? Now, that might be the fact that in the past, the patient has actually transformed into the accelerated phase or the blast phase. I'd regard that as a contraindication to a stopping drug. What about urgency? Is there any urgency to do it today, or can we wait another 6 months or 12 months? Maybe that's a better time to try. I think in most cases, the longer you wait, the better the chances of success. So that's something to consider. What's the motivation to try and stop? Some patients have virtually no symptoms at all on their current drug, and there's no great motivation to stop. And I'm not really one to push a patient to stopping if they don't really have the motivation. But of course, many patients are keen to stop because they do have day-to-day side effects, or they're concerned about the toxicity of the drugs long term. Is the patient emotionally and mentally resilient? Because, as I said, it can be psychologically stressful. And of course, one of the important things to discuss is what are the chances of success if we do it today, and what are the chances if we wait another year or 2? And in most cases, we can make a calculation. When we're getting more and more precise about that calculation, about what are your chances of success, overall, we're not enthusiastic to try and stop if the chances of success are less than 50%. And these are the recommendations that have come out from the European Leukemia Net on the left and from the American recommendations on the right. I won't go through all of these, just to say that they're pretty much in agreement that you need to have a patient who has had at least, in the case of the European recommendations, at least 5 years of drug if it's Imatinib, at least 4 years of drug if it's a second generation kinase inhibitor before thinking about stopping, whereas the Americans think 3 years is enough. Otherwise, the recommendations are fairly standard. You need to be in a deep response, which we call MR4, for at least 3 years. That would be optimal. And MR4.5, which is even deeper than an MR4, for at least 2 years. So there's a fairly good consensus now across both of those recommendation panels. So the ELN have stated that the goal of therapy in 2020 is normal survival and good quality of life without lifelong treatment. So that's really acknowledging the fact that we should be aiming to get every patient, if we can, off their drug. The vision for the next 5 years is that more CML patients will successfully achieve treatment-free remission, and that it will be possible to talk more confidently about the curability of CML. So I think that's really aligning with my belief that if we're really proactive about treatment-free remission, I think we can, over the next 5 to 10 years, get the majority of patients into a treatment-free remission. That is our challenge. In Adelaide, just to show that over our patients, around about 300 patients that we've followed over many years, I can show you that this red line represents the number of patients who are eligible to stop. Okay, they've had the criteria, so very few at 2 years, no one at 2 years, a few at 4 years, but by 14 years, the majority of patients are eligible to stop. How many have actually tried to stop in Adelaide? Just about all the patients who are eligible, with a few exceptions. How many have succeeded? Well, as you might expect, it's not a guarantee. Just over half have succeeded. So we now have about 35–40% who are in treatment-free remission, but many of them went through 12 or 14 years of drug before they got to that point. And that's because with Imatinib, it can take many years to become eligible and to stop. Whereas with the second-generation drugs, I think it's more realistic. We're going to see similar outcomes within 5 to 8 years rather than 10 to 14. I just briefly mentioned Asciminib. I'm very excited about this new drug. It is also a tyrosine kinase inhibitor, but it binds to a different site on Bcr-Enabled. And because of that, it doesn't seem to have the same toxicity because it doesn't affect other kinases. And that's a very important characteristic. And so far, what we've seen, we've treated about 25 patients in Adelaide and about 250 around the world. And we're not seeing the same levels of side effects or toxicity that we're seeing with Imatinib, Nilotinib, Dasatinib. So I'm quite excited about it. We're about to start a trial around Australia where patients with newly diagnosed CML can start therapy with this Asciminib drug. And we're going to be very interested to see how effective it is compared to the other drugs that we use today. I want to finish by mentioning this really exciting development that's been pioneered by the Leukaemia Foundation with the support of the federal government, a national strategic action plan for blood, a once-in-a-generation opportunity to reduce the impact of blood cancer and reimagine the way care and treatment is planned and administered across Australia. And the vision is for 0 lives lost to blood cancer by 2035, underpinned by 0 preventable deaths, regardless of geography or background. We know they can be limiting factors in some cases, through equitable access to best practice treatment and care across all Australians. And I'm very honoured to be one of many people, many haematologists and other parties that are involved in this blood cancer task force. Been working very hard to put together these recommendations. And the priorities are shown here as 4 things: clearly achieving best practice, using the right drug in the right patient throughout Australia, empowering patients and their family so that no patient feels that they're not getting the very best treatment and not getting heard about what they want for their disease, enabling access to novel and specialised therapies such as Asciminib, and allowing patients from right around Australia to have access to these sort of drugs, and of course accelerating research so we can develop the best and the most effective and safest drugs to treat these blood cancers. Many partners are involved in this development, and I'm really excited about the direction this is going and the fact that we have support from the federal government to make this a reality. So in conclusions, we have 4 excellent tyrosine kinase inhibitors available. The potency and the side effects profile for each one varies, so the challenge is to find the best fit for each patient. Treatment-free remission is central to the treatment plan from diagnosis for most, but not all CML patients. And I would argue that a proactive approach to the achievement of a deep molecular response and hopefully treatment-free remission can steadily recruit more patients to treatment-free remission over the long term, and also to let you know that there are exciting new drugs like Imatinib on the horizon that may give us even better outcomes and lower toxicity over the long term. And stop there and acknowledge that many things that I've talked about today. Acknowledge the CML collaborators right around Australia, my own CML research team in Adelaide, and of course the CML patients that right around Australia have contributed critical permissions to join our studies, to give us their samples so we can study the disease in more detail. Without that, we wouldn't be able to make the progress we have over the last few decades. Thank you very much for your attention.
Fantastic. Thank you very much for that wonderful presentation, Tim. It really hit on. We've got lots and lots of questions coming through. We've got about a bit over 10 minutes to try and attack as many as possible. And not surprisingly, those 4 priorities which you mentioned in one of the last few slides about accessing best treatment, about information and support, research. These are the things that are really coming through in the questions, which is fantastic to see. So first one. This is probably a little bit more about support and information, but any advice on diet, any specialised diet that you might recommend, or what are some of the things you tell your patients in this realm?
Yeah, I think given our understanding that if we're using the 2nd generation drugs, there may be some increased risk of vascular events in the longer term, particularly for patients over the age of 60. So I think diet and physical activity are incredibly important. These are the things that we need to address to minimise the risk of these sort of events, as well as attention to the cholesterol level. And in many cases, we need to use lipid-lowering drugs such as statins to modify that. Blood pressure needs to be very carefully attended. All these things are really important. Fortunately for Imatinib, there doesn't seem to be a higher risk of these vascular events, but for all the other drugs, they are a concern, and we need to be very focused on optimizing those things that we can do something about.
Excellent. I'd probably just add in there, Tim, recommending an accredited practicing dietitian to engage if you are looking to explore that space. Somebody who understands the human physiology and particularly if you can find somebody who has expertise in cancer and blood cancer in that space as well. Next one, a few questions came through about. For people that are having a go at TFR, coming off their drugs, coming off their original TKI, what would be considerations if they needed to go back onto their treatment in regard to can they go back onto the original TKI?
Yeah. Okay. Generally, we will prefer patients to go back on their original TKI, because we want to get their leukemia level down quickly, back to where we know it's a safe level. So if they've gone up above 0.1%, we don't particularly want to try a different drug because sometimes the different drug will not be tolerated well. It might have to stop therapy. And so you don't want to muck around in that first month or so after you restart drug. Of course, after that, once you've got them back down to a deep molecular response, you can have that discussion. Is there a drug that would be a better choice? Particularly for a patient who's had a rapid relapse, they might want to think about taking a different drug that might give them a chance in the longer term of a second attempt at treatment-free remission, which we do look at in some patients. So it's a legitimate discussion, but I think it shouldn't be at the time that a patient needs to restart drug. I think that point ideally is a time when they've already got their drug with them. They know they tolerate that drug. They just stopped it 6 months ago. So going back on it again is a pretty safe and effective way of getting them back down to a deep response. But beyond that, of course, there's always the possibility of thinking about other choices.
Excellent, thank you. Next one I'll read out just on research. Has any research looked at the potential of reversing the fusion of Bcr-Enabled genetic mutation? Great question.
Reverse the fusion.
Yeah.
Probably before we had the tyrosine kinase inhibitors, there were attempts to actually try and directly prevent that fusion gene from producing a protein, and there was limited success. And it just worked out that these drugs, which are so convenient to take but are so effective at switching off the activity of Bcr-Enabled, has kind of killed that research because they involve very challenging delivery of genes into cells, etc. Whereas this is TKIs are such a can be mass produced and stable at room temperature. All those advantages that allow us to use these drugs right across the world now, and in almost every country, not quite every country, but almost every country. Very simple to keep them stored and keep them active. Whereas any sort of gene therapies type approach like that would be only available for a very few and at very great expense. So luckily we don't need it in CML, whereas we probably do need it in other blood cancers.
Excellent, thank you for that one. A quick question on combination TKI therapy. Do you want to make a few comments about that? A few questions coming through about research about combination TKI therapy.
We have looked at that in the past. It's not very practical to combine, say, Imatinib with Nilotinib or Dasatinib. It has been tried in very limited way, but the toxicities tend to sort of combine somewhat, and the benefit's not that clear. However, Asciminib, because it binds at a different site, you can actually combine Asciminib with, say, Imatinib or Nilotinib or Dasatinib. So that combination is being looked at the moment. There's actually a trial going on in Germany using that front line, using Asciminib plus one of the TKIs, because there you get the additional potency without getting the additional toxicity with the combination. So it's got some interest.
Excellent. Next question coming through. They're not getting any easier. Is the abnormal Philadelphia chromosome inheritable from either parent if they have the mutation? No,
fortunately, you never see that mutation in the germline, which is where you pass on your eggs or your sperm. It's not present there. It's an acquired mutation, so it happens sometime, and then in one cell in the bone marrow, and then that becomes 2 and 4 and 8, and before you know it, you've got 100 million cells in the bone marrow that all have that same genetic mutation, and you've got CML. But it's not, you don't transfer it to your kids. There's no problem there. So that's something which you haven't got to worry about.
Excellent. Next question. Is there any research looking at monitoring CML levels without blood tests?
Well, we used to monitor it with bone marrow tests. Before we had very accurate PCR from the blood, patients would have a bone marrow every 3 or 6 months. And if you're a patient who's been going for more than 20 years, you'd know about that because you'd be pretty used to having bone marrow tests. I can say patients do prefer having blood rather than bone marrow. Can we get better than that? Can we do a breath test to detect it? Or it's hard to imagine. I think that blood is here to stay. I think it'd be an amazing test if you could somehow put a detector on the wrist and count the number of transcripts as they go past in the blood. But who knows what 25 years will get us to.
Absolutely. There's lots and lots of questions coming through about, I suppose, specifically about questions about individuals and their own circumstances. Did you want to, I suppose, just make a comment about that?
I think it's really pretty unfair for me to just give a quick opinion about somebody's situation, because they'll provide 2 or 3 facts about their current circumstances, but I don't know the full background. I haven't seen the patient. I think to throw out you can stop, no, you can't stop, it's not really appropriate. That is a clinical decision based on knowing the patient very well, all of the clinical history, how do they fare in the first few months of therapy, how are they psychologically, all those things need to be factored into it. So to simply say tick cross is not really appropriate. But I can talk about broad principles, but not specifics.
Definitely. Moving to, got a few more minutes for some more questions. There's been a fair few questions about side effects about vascular damage in the eyes. Do you want to make some comments about that? We've got 2 or 3 questions about that.
Okay, I haven't seen problems. I mean, we certainly see patients on Imatinib certainly do get conjunctival hemorrhages, and they can look awful, and they're a bit unpleasant. They sting a bit, but they don't cause any long-term damage at all. They're more an inconvenience. We can often reduce them by using drugs that reduce the fluid retention, such as diuretics. So that may be what they're referring to. Otherwise, we don't really see a lot of problems with the eyes.
Excellent. All right, lots of thank yous and lots of people putting in there celebrating their 25 year anniversary with CML. So it's fantastic to see some of those comments coming through. I wanted to ask you a question. You've obviously been a key part of the blood cancer task force and representing the whole CML community on that really exciting piece of work. What has been one of the most exciting things, do you think, coming out of that program of work from your perspective, whether it be from research or from any of those four areas you mentioned?
I think the understanding that at the moment some patients in the rural areas and in isolated areas are not getting the equivalent capacity to get their blood cancers treated, and that needs to be addressed as an urgent issue. And the fact that that's been addressed very strongly in the task force recommendations, I think, is a very important development. I think we'll see some good responses on that from the government. I obviously also hope that they will see that underlying all these things, high quality research needs to be supported, because we're not going to get the next great drug or the next great way to understand how patients can come off drug without a lot more research and support for research, which is clearly struggling at the moment with the COVID-19. Philanthropy has been a challenge, and we want to remember that while COVID-19 needs a lot of addressing, so do all the cancers, and particularly the blood cancers.
Absolutely. I think you just segued into my next question that I wanted to ask you as well, about given that the experience of COVID and the change that we've seen across the healthcare sector, do you want to make any comments on telehealth itself and your experience using telehealth, some of the benefits, some of the challenges?
Look, I mean, we had to use telehealth for all our patients for about 3 months, and actually I found it really quite good. I mean, it's probably 80% of what you get out of a patient visit can be done on telehealth. And I think as a one-off, it was a very convenient thing for both me and for the patient. But I don't think it's a long-term strategy. I think you do need that face-to-face. You need to actually have that dynamic interaction in face-to-face. So I think it could be like used as an alternate visits, could be telehealth. But we're not going to get away from the need to see patients, to check their to do the physical examination, to understand the nature of their rash or their pleural effusion or whatever it is. Can't do all those things by telehealth, but you can certainly do a lot. And I think it's shown me that we can run our clinic more efficiently, perhaps by doing alternate visits, telehealth and face-to-face. It's going to be more convenient for everybody.
Excellent. Well, I think we're just about out of time there. Thank you so much, Tim, for your time today. We've thrown a hell of a lot of questions at you, and we're really grateful you've been able to present such a wonderful presentation for the whole CML community, and what is Blood Cancer Awareness Month and World CML Day. And again, we really thank you about all of your wonderful work that you've been doing on behalf of the blood cancer community and the Blood Cancer Task Force. Really excited to see a lot of that work come to life.
Great. Well, thank you very much. It's been a pleasure, and all the best to everybody on World CML Day.
Thanks, Tim, and thanks everyone. We'll conclude the session now.